Okay.
All right. So yes, thank you. Yes, so I'll start. Okay. So thank you so much again for having me for this annual meeting and the first anniversary. I would like to start with thanking Sanjeev for arranging this, and also gratitude to all my teachers and seniors that are here. I can see Dr. Yadav is here, Dr. Anil sir is here. So again, gratitude to them. So yes, so today's topic, I'll be talking about this new concept which is gaining more popularity in the world of low back pain or spine pain these days. This is called vertebrogenic pain. So next slide. So basically, spinal pain can be characterized or divided between anterior column, middle column, or posterior column pain. Anterior column is mostly it's arising from vertebral body or disc pathology. Middle column is usually more nerve-related radicular pain, and posterior column is usually more facetogenic or facet joint arthropathy or facet-related pain. So for vertebrogenic, of course, as the name suggests, it is originating from vertebral body. So this is more or less falls into that anterior column category. So anterior column category, we all know about the degenerative disc as being the cause of low back pain for quite some time. But now the newer concept that is coming out is that because of these degenerated discs, over the period of time, the vertebral end plates can be the pain generator and cause low back pain, which is a cause of like concern for quite some time because there were no optimal options for management for such situations. So the way you can do the next slide. Next slide. Yeah. So as you can see, the disc pathology is, of course, we have the pulposus in the center, annulus fibrosus outside, and the vertebral end plates, of course. The purpose of intervertebral discs is mainly to provide adequate spacing between the vertebral bodies and also to provide cushioning. But as the discs start degenerating, which is a normal, inevitable phenomena of physiological aging or even trauma-related or repeated vertebral load or axial load, then this leads to degeneration of the discs that can cause annular tears. This can cause leaking of the pulposus to the periphery. And this starts the interplay of inflammatory changes between the vertebral body or vertebral end plate and the disc. Now, next slide, please. As you can see that the vertebral end plates, when they become inflamed, they can cause pain. And this is usually sensed by these nerves. And these are called basivertebral nerves. These yellow lines that you are seeing within the vertebral body, these are the basivertebral nerves. Yes, thank you, Sanjeev. And this basivertebral nerve basically arises from sinovertebral nerve, which is basically a branch from ventral ramus. And the sinovertebral nerve also gets a communication from gray rami, which is a connection from a sympathetic chain. So the sinovertebral nerve is usually a nerve innervation of posterior part of the disc, periosteum of the vertebral body. And this carries both nociceptive as well as proprioceptive feedback from the posterior part of the disc and vertebral body. But when they branch out to basivertebral nerve, it enters into the vertebral body through the vertebral foramen in the middle part and posterior part of the vertebral body and can branch superior and inferior. And then these are the nerve supply or nerve innervation for the vertebral end plates. So if vertebral end plates are pathologic or the source of pain, these nerves can sense this pain and of course the major cause of low back pain basically. So next slide. Yeah, next slide. So as you can see in this picture, the exact pathophysiology, how the vertebral end plates can be the source of pain. A normal healthy looking disc, which is A, the disc material and the vertebral end plates. And as with the repeated injury to the disc or repeated degeneration of the disc, there is a constant interplay between the disc material and the end plates. And histological study shows that almost 20 pro-inflammatory markers are actually seen, mostly prostaglandins E2, nitric oxide, IL-6, TNF-alpha, and these all can cause disruption of the vertebral end plates. And in some studies, we were able to see some infection or some bacteria was also grown, but mostly it's the inflammatory markers that can irritate the vertebral end plates. Now, because if vertebral end plates are irritated, or we can use the word damaged also, because this can cause some irregularity of the vertebral end plate also. This can be sensed by the basivertebral nerve and can cause low back pain. Next slide. Again, the same diagram, how this vertebral end plates can sense the pain through this basivertebral nerve. And this is the picture of the radiological picture, and this is how and where this basivertebral nerve, which is a branch of sinovertebral nerve, enters the vertebral body, which is through the basivertebral foramen. On MRI on the right side, you can see that it's in the middle part, the white thing, the bluish arrow or bluish greenish arrow that you can see. This is where they enter the vertebral body and then branches out superior and inferiorly. Next slide. Now, the algorithm, how to identify whether the discs or the vertebral end plate is the cause of pain, and in particular, how to proceed about the diagnosis and management of these patients. So mostly patients with the discogenic or vertebrogenic back pain, they present with this chronic, non-specific, midline lower back pain. And because it is more or less anterior column pain, pain is usually worse with bending forward. Patient usually says that I feel this pain in my middle of back, which is there if I sit for more than 10 minutes or 15 minutes. It feels like deep ache, sometimes burning sensation, doesn't go down to my buttocks or legs, and it's debilitating. And there are days when I'm okay, but then there is a period like 7-8 days or 9 days or 10 days when the pain is like excruciating, that I cannot function, I cannot work. And typically, the day-to-day activities like driving, like lifting, sitting, bending forward, any activity like running, exercises, these all can aggravate this back pain. How to differentiate this from the other component, which is either nerve related or facet joint related, is usually those type of pains are more like radiating pain, or usually worse with extension rather than flexion. So that's the key presentation or the key history element that the patient tells us, which made us think that, okay, this is anterior column, this can be the disc or the vertebral end plates. Next slide, please. Now the important thing is imaging. As we all, of course, after listening to the patient, of course, after doing our physical exam, which I will talk about it in a bit, the third most important element is imaging studies to identify whether it's the vertebral end plates, it's the disc, or it's the pinched nerves, or it's something else that can cause this pain. So the changes that we just discussed histologically, which is initial inflammation or edema or fluid accumulation in the vertebral end plates, can be picked up by MRI. And MRI usually shows, next slide, Sanjeev, you can do, next slide. So you can see that there are modic changes. So Dr. Modic is one of the radiologists who come up with these changes and correlated anatomically. So he showed that during the acute phase, which is the type 1 modic changes, there is edema and inflammation in the vertebral end bodies, vertebral end plates. And this usually is white on T2 images, and it's usually black on T1 images. And if you can show to the next slide, please. So this is an important diagram. As you can see, the top line correlate type 1 changes with the top line, which is black vertebral end plates on A image. Sorry. And white end plate changes on B image. So this is modic type 1 changes. You can go to the previous slide now. And then comes the next stage of degenerative changes, which is type 2 modic changes. In this stage, which can be characterized as a subacute stage, the acute inflammatory changes are replaced by fatty tissue or fat. And this is usually called type 2 modic changes. If you can go to the next slide. This usually looks like the C and D, which is white on both T1 and T2 images. So this is characterized as type 2 modic changes, and you can go to the previous slide now. And the type 3 changes, which is a chronic stage, this is the stage where everything is replaced by fibrous tissue or sclerosis. You can see the green lines. And next slide, please. And this usually looks on MRI like black on T1 weighted MRI images and black on T2 weighted images. So this is a very important way to diagnose using MRI studies. Now, if let's say patient can't have MRI because of contraindication, because of any metal in the body or pacemaker or other things, the other test or commonly available test that can be done in terms of radiology is CT scan. Now, CT scan doesn't show all these modic changes, but it can actually show the damage to the vertebral end plates. You can actually see irregularities or sclerosis. You know that those kind of changes can be seen on CT scan. So of course, it's not the perfect study, but at least it's an option to look for the imaging findings in presence of clinical findings and in presence of history findings. And other radiological study, which is very like difficult to do, but it's gaining more popularity these days thanks to our nuclear medicine colleagues, is SPECT scan. Now, SPECT scan is basically it's wherever there is increased metabolism or inflammation, there is increased uptake. So normally during type 1 modic changes or acute phase where there is edema and inflammation, the SPECT scan actually shows lightening of the vertebral end plates. So these are the three imaging modalities that can be done. Most commonly, of course, MRI of the lumbar spine. Usually non-contrast MRI is good enough in combination with the physical exam findings and of course the clinical presentation. So next slide, please. So yeah, these are the same modic changes that we just discussed, type 1 and type 2 modic changes. Next, yeah, diagnostic. Yeah, you can go to the next slide. Yes. So as we discussed about how to diagnose these patients. So clinical presentation, of course, in our area of medicine, physical exam is important, but even more important is history or the clinical exam. We need to listen to the patient, what they are saying, because they give us so many clues where 80% diagnosis is already made, and rest is, of course, physical exam and then imaging findings to correlate. But yeah, history is very important. Mostly patient says pain with sitting for a long time, mostly with bending forwards, and any increased vertical load on the spine like jumping, running also can aggravate back pain in absence of any radiating leg pain. Now that is important, that if patient starts having radiating leg pain, then we have to think of other diagnosis. Now, physical exam, as of course, being physiatrist, this is our forte. This is where we have to be very, very meticulous, because what we are doing in our physical exam is not only to isolate or identify whether this is an anterior column pain, but also like prove or do an exam to make sure that it is not posterior column or radicular pain or something else. So in addition to ask the patient to do a like stand and bend forward or sit and bend forward exam to reproduce the midline low back pain, other component is equally very important, like doing our lumbar ipsilateral facet load test, which is like asking the patient to lean to the right side or left side and ask them to do extension, and if we can reproduce that pain. So that's like we have to like have a negative ipsilateral facet load test. We should have a negative straight leg raise test or reverse straight leg raise test, and we should also do our provocative exams for the sacroiliac joints like Ganslins or Faber or thigh thrust or pubic compression. I normally recommend all my colleagues to do at least 5 of those SI joint provocative tests, because believe it or not, SI joint is not that uncommon in our practice, especially in our patient population that we see. So after doing all these exams, of course, you have to do your regular neuro exam to make sure that there is no leg weakness. And of course, the gait assessment is also very, very important, because gait asymmetry or patient pronating or supinating or leg length discrepancy, all these things are equally important or very, very important. And only being a physiatrist, I mean, I can take pride in saying that we have that tool where we can actually look into the biomechanics and actually give some biomechanical intervention to help the patient, which luckily or unluckily other providers or other specialties cannot. So we should implement all these things in our physical exam. And as discussed, MRI imaging studies, MRI SPECT scan and CT scan, of course, in the order of superiority, I would say MRI is the best. But if MRI is not possible, then CT scan should be considered, and SPECT CT scan in, of course, tertiary care settings is a wonderful tool to have. Next slide, please. Now the question is about how to manage these patients. Of course, the first line treatment for our patients has to be, we have to ask them to strengthen the core, do the regular stretching. Of course, activity modification is important. Now I'm actually going this order because this is how I've been taught by my teachers, Dr. Yadav and Dr. Singh. Like, you have to start with the physical therapy prescription first, and you have to start with activity lifestyle modification first, because remember, we are the physiatrists first. So you start with that. Then of course you talk about the medications. Usually, we prescribe NSAIDs or paracetamol, or in some cases opioids. Of course, chronic opioid use for degenerative back pain or degenerative conditions is not a good idea, but of course should be considered for short-term use, usually when the pain is severe, when the patient can't even sleep or function at all. Now then comes the last part, which is the interventional part. Now, interventional part is usually reserved for the patients who have already gone through the full grind of conservative treatments, and they have already failed at least 6 months of the treatment. Now, we can say that when the patient is in severe pain, we can try our epidural steroid injections or oral steroid injections to manage that acute pain. You can try that, but again, the treatment options that I'm actually going to discuss now is reserved for the patients who have already gone through at least 6 months of the treatment, not before that. So the treatment options, which is gaining more popularity these days because of the anatomy that I just discussed with you, that we have a treatment option available now where we can target this basivertebral nerve to manage the pain. So you can go to the next slide, please. So this is the option we have now. Like, of course, in pain medicine, what we are doing these days to manage pain is, in terms of interventional procedures, is either we are stimulating the nerve or we are ablating or burning the nerve. So in continuation to that, now that because we have a better understanding of the anatomy, the target is the basivertebral nerve, because if we can ablate this nerve, we can actually manage the pain coming from these vertebral end plates. And the target is basivertebral nerve. As you can see that it enters through the middle part of the vertebral body on the posterior aspect, and then it branches superior and inferior. And next slide, please. So this is the treatment option that is now gaining popularity by the name of intracept or basivertebral nerve ablation. Now I can, of course, it's different in different parts of the world, but at least in United States, we have an approval for certain levels only that we can do. It's now, right now it's approved between L3 and S1. And I'll talk a little bit more about this procedure. And just a brief overview, of course, will not go in detail of for this procedure, but it's not a complicated procedure at all. You can go to the next slide. So for those of us who are already doing vertebroplasty for compression fracture, the basics remains the same. Like, you gain the vertebral body through the trocar and cannula, like the bone introducer, where we use fluoroscopy views to perform this procedure. Now, just like vertebroplasty, like the patient is in prone position, we use either 2 C-arm for AP and lateral views, or just 1 C-arm, and we of course do back and forth AP and lateral views. But the idea is to square the superior end plate of the target vertebra, make sure that it's a true AP with spinal process in the middle line, and then of course use either the extrapedicular or transpedicular approach to gain access to the vertebral body. You can go to the next slide. Now, this is going a little bit more in detail about the procedure itself, but the bottom line is that you gain access inside the vertebral body, and then you pretty much hammer in this stylet. And then next slide. Yeah, you can go to the previous slide actually. Yeah, so basically you hammer in this stylet, and then this radio frequency probe, and then this is connected to the radio frequency generator. The guidelines suggest that the ablation should be done at least 15 minutes for the setting of 80 degrees Celsius. So that's the consensus statement right now from most of the societies. However, I do have some colleagues here who are doing this, and they are suggesting that even 8 minutes is good enough. So 15 minutes of cooking is usually not required. 8 minutes is good enough, but current guidelines suggest 15 minutes. And Again, the post-operative or post-procedure care is you can just send the patient with simple Ultraset or Tramadol or just plain paracetamol, and this can be done under conscious sedation or a monitored anesthesia care or MAC. Usually that's good enough. You don't even need to give general anesthesia for these patients. So yeah, that's about the procedure that we have these days, at least available with the evidence also. So this is the algorithmic approach. Basically, a patient tries at least 6 months of conservative care, and we have to make sure that it's more anterior column pain, and then MRI is usually helpful along with physical exam and of course history, and then this is the treatment option that we can do. Now there is argument that how to differentiate whether it's a vertebral end plate or vertebrogenic pain versus it's a discogenic or disc related pain. Now, if you ask me personally, I don't know how to differentiate because, of course, we used to do discograms, like provocation discograms, to see whether the disc is the problem or something else. But I mean, that thing is also falling out of favor because the results or the report that patient gives us is sometimes not that reliable. And we still do that procedure when surgeon asks us to do because the surgical option for something like this is spinal fusion. So we do the discograms, and if it is positive, we can say that it is more of a disc problem than the vertebral end plate problem. But in terms of physical exam, there is no way we can identify or isolate from even from history standpoint, very difficult to differentiate. Maybe with MRI, if you see vertebral end plate changes or modic changes, you can say it's a more vertebrogenic pain than a discogenic pain. So that is the only thing that I can think of which can differentiate between a disc pain or a vertebral end plate or vertebrogenic pain. Next slide, please. So about the evidence for this procedure, there is a high quality prospective randomized controlled trial which is ongoing for more than 5 years now. And I mean, the major factor or major indicator is either functional improvement through oswestry disability index improvement and pain improvement on visual analog scale. So as you can see that the results that is available right now is for like 3 months, 6 months, 12 months, 24, 3, 4, and 5 years. So there's a robust data available right now as long as a 5-year follow-up. And then you can see a major drop from like baseline of 7 to a baseline of maybe a 2. So that's a clinically and statistically significant improvement in visual analog scale over the period of time. It's not just 3 months or 6 months, but it's all the way up to 5 years. So there is definite clinical and statistical improvement that is seen basically with this procedure. So you can do the next slide. So this is the improvement. Yeah, there are various studies going on. This is a SMART trial basically that is going on, which is looking at VAS, like visual analog scale, as well as oswestry disability index. So next slide, please. So yeah, I mean, the purpose of doing this talk is to invoke that, or is everyone to think about this as the source of pain. Again, in our field, I do see this. I'm doing this for like about 20 years now, that we get very excited whenever a new procedure comes, and then we talk about it, and then after 5 years we say, oh no, it was not that effective. But at least it's important to understand the diagnosis, and important to understand the source of pain. Our vertebral end plates can be the source of pain. Understand the pathophysiology, because pathophysiology makes sense. If you understand that, yes, this makes sense clinically or histologically, then we are on the right track. So to understand the that vertebral end plates can be the source of pain, to understand that there is enough histological evidence that yes, they can be damaged or irritated and can cause pain, and there is of course radiological evidence also which can validate that. And at least for now, we have an option which we can offer to these patients and consider to improve their quality of life. And the last point I just want to mention is about the North American Spine Society's position statement about doing spinal surgeries for this patient. So luckily, my chairman, current chairman, he's the ex-president of North American Spine Society, and he did told me that as a surgeon, I mean, he would not recommend fusing these patients because with spinal fusion, they do see a lot of issues over the period of time, especially adjacent segment issues like pseudoarthrosis or adjacent segment, stenosis or arthritis and more issues. So they would rather not fuse these patients. So as a surgeon, they are more than willing to not do fusions and ask us maybe moving forward to do these kind of procedures and manage these patients. And the role of rehabilitation is always important: activity modification, patient education, exercise program. So that always remains the mainstay of the treatment. So that's pretty much all from my side, and thank you so much for having me again.
Thank you, sir. Thank you, sir, for the it was a really eye-opening lecture for all of us. So, first of all, any questions? I guess I would like to see what are the questions in the chat box. So, Dr. Rambir is asking that how effective this basic vertebral nerve ablation procedure is for vertebral mats pain, metastasis pain.
So this procedure is not indicated or approved for the metastatic pain as of now. For metastatic pain, you still do your vertebroplasty. That is still standard of care. So this is not for the metastatic pain at all.
Okay, okay.
Yeah, but you
But
do
actually,
vertebroplasty. Yeah.
but actually, in metastasis also, the metastasis will cause the irritation of these basic vertebral
Yes.
nerves, and it will cause. So I think it was not still not. I think not trial has been not been done for these
Yeah, it's not
cases.
been studied at all. But
Yes,
standard
sir.
of care for now for pathological metastatic fractures is vertebroplasty. Vertebroplasty, there is enough studies has been done, and there is definite clinical evidence and standard of care for now that we do vertebroplasties for these patients. So, but other
So,
than that, this procedure is not studied at all for
but
metastatic pain yet. Yeah.
okay. So next question is role of any antibiotics in Nordic type 1 changes.
So that's, yeah, again, I have yet to see any studies, but there was one study where they talk about that some microorganisms was grown during histological studies. So it may has a role, just like we know about knee osteoarthritis, that there is one bacteria, one study, or there's actually more than one studies these days. They look at doxycycline for treatment of osteoarthritis. So I would say the same thing, because here the pathophysiology is the same, that it's the degeneration of the end plates, just like degeneration of the articular surfaces. So I would say definitely it's a possibility. Yes, I would say yes.
One more thing which I would like to myself ask, what I have seen in type 1 body changes that they have in type T1 images, they have hypointensity on T1 and hyper intense on T2. Type 1,
Yes.
type 1 body changes, na? So,
Yes. So
but in cases of discitis or port spine and metastasis also, we are having a similar change that changes that like hypo intensity in T1 and hyper intensity in T2. So in a
yeah.
case of normal MRI, if we see how to differentiate whether this is either infection or some metastasis or this is traumatic changes. So how should we discriminate
Well,
on that?
I mean, then in that case, you do biopsy if you're worried about discitis, or if you're worried about POTS, then you do biopsy basically. But again, you have to look at the full picture, right? You have to look at the patient. That's why history is important. That's why physical exam is important. I mean, a patient with port spine, you will get an idea. Like the patient presents with, of course, evening pyrexia or weight loss or cachexia and those kind of things. So, but if you are looking at a patient which is pretty much fine, no problem otherwise, and then you are seeing these changes, then usually these are your basic changes. And then again, the findings are more pronounced when it comes to osteomyelitis or port
Yes.
spine. They are like more, you see not just modic changes, you see like erosion of the end plates, you see a lot of different changes. So the findings are definitely more pronounced. And again, if you are still suspicious, then you do biopsy. Then you ask the radiology colleagues to do the biopsy.
One question from Dr. Ashish Yadav. Effectiveness of biaculoplasty versus BVNA in vertebrogenic pain. But
Yes.
Dr. Ashish, this is a biaculoplasty is done for the discogenic pain actually.
Yeah. So I
So
can, yeah. So again, this is what I'm seeing a lot these days, that, question is what to do with the disc problem. If it is a disc issue, what is the treatment for that? And like, let's say if we are seeing disc degeneration or annular tears or high intensity zone on MRI, but there's no modic changes, then what is that? And the patient still has more anterior column pain. So again, the thing is, that there are not many effective treatments for discogenic pain. That's the fact basically. We tried injecting discs with steroids. We injected these discs with the methylene blue in the past. Nowadays, allogenic stem cells or allogenic mesenchymal cell injections is also, they are being studied. But still, we don't have any effective treatment for discogenic pain. I mean, people tried intradiscal electrothermal therapy also. I never did that, but by the time I came into the practice, that treatment fall out of favor because of the poor outcome or not high quality studies. But for disc issues, we don't have an effective treatment, and all the treatments tried so far, the studies are not showing any convincing evidence that it works.
So what
So
is your practical experience with bioplasty for discogenic pain?
I've never done that before. I've just done intradiscal steroids. I've done
Okay.
intradiscal methylene blue. And right
Okay.
now, the standard of practice is that if I think patient is, or what I'm doing these days is, if I think disc is the problem, I just do the provocation discography and then I ask the surgeon to consider fusion basically. That's all I do for discogenic pain these days. Yeah.
So for annular tears, they are visible on MRI and the patient is having consistent symptoms. So
Yeah.
do you do intradiscal steroid injection for that?
I've tried that. I've tried in at least 10 or 15 patients in last 5 years or so. Poor outcome. Poor
Poor
outcome. I mean, they
outcome.
get better for maybe few weeks, but then what, basically?
Okay, okay.
So yeah, so
And
that's why, I mean, again, I try to tell patients that, you know what, you really want fusion. If is your quality of life that bad that you want hardware in your back for a degenerative disc, because degenerative disc is, there is no treatment as such. There is there are, I mean, there are few doctors I know of in my practice, they are talking about doing artificial disc replacements also, which is not a bad idea. At least it's better than doing the spinal fusion, because you don't have to worry about fusion related issues like adjacent segment issues or pseudoarthrosis. But even the outcome of artificial discs is not convincing, at least in lumbar region as of now. I know for cervical spine, artificial disc replacements are pretty good, but for lumbar region, artificial disc replacements, again, the house is divided right now, at least in the spine surgery world. I have like talked to a lot of doctors who are saying that lumbar disc replacement doesn't work, but then I met few spine surgeons who do think that that's the only effective option we have for the discogenic pain at this time.
so have you any experience with the role of any PRP injection over this degenerated disc and end plate area through the intradiscal route? Any experience through that of the thing? Any
Yeah, so
experience?
I don't have any experience, but I would say definitely it's worth trying. It's
I
better
see.
than steroid, of course, so it's worth trying for sure. But I have not done that. So that's the thing. The problem is, of course, practicing. I mean, and I have the experience of working in India, and of course now I'm working here. So I can tell you that here you have to go by whatever is approved, basically FDA approved. You cannot try any investigational or experimental treatment unless you are doing a study on a patient. So that is the issue. But I can definitely tell you that if PRP works in the knee joint, which is degenerative condition, why not in the spine? So it's
Fine,
worth trying
definitely.
for sure. Yeah.
Definitely, definitely, sir.
Yeah.
Sir, one question from Dr. Arna Shukla that the imaging for vertebrogenic pain is not a spot on diagnosis on MRI or CT scan or even SPECT imaging. So can we simply say that the pain is of vertebrogenic origin when clinical findings are there, that is the pain on flexion activities, and plain radiographs show vertebral end plate and plate sclerosis of some cortical changes? I think yes.
Yeah,
So
I mean, answer is yes, but important to understand that so again, the natural course of the disease progression is important to understand. So the usually the way things start, it starts with the degenerative disc first. Like disc starts degenerating, and then with time, over a period of time, which can be like, again, according to the studies that I did research, that the time between the discs starts degenerating and the vertebral end plate starts degenerating can be a 10-year difference. Like, you can have, like, in late 20s your disc starts degenerating, or mid 30s, but by late 40s or late 50s you will see vertebral end plate changes. So that how much the cascade or the natural course is. Like, you starts with the disc degeneration, And then over the period of time or a decade, the vertebral end plate changes happen. And then if you are in acute phase, you will see MRI changes or modic changes on MRI. And then when that also becomes chronic, then you don't see anything on MRI, but you can still see some vertebral end plate changes on X-rays or CT scan. So that's more like a chronic stage then.
Dr. Vasudha Ghoshal is asking that what is your opinion if modic changes type 2 and 3 and also this prolapse intervertebral disc coexist? Okay, what I think he's asking how will it differentiate between discogenic and vertebrogenic pain? So
Yeah,
I
so
think
again, they're very difficult to differentiate if you ask me, because the only thing I can think of is a provocation discogram, where we put the dye in the disc, of course, and ask the patient. I don't think that's reliable, but that's all we have basically to identify whether it's the disc or the vertebral end plate. But the question again is, let's say we isolate that it's more disc than the end plate, or it's more end plate and the disc. The question is what type of treatment you offer it to them. So why modic changes are important is because at least for acute or subacute changes, which is modic type 1 and type 2 changes, there is a evidence-based treatment that can be offered to these patients. Or at least in this stage, we can discuss with the surgeon that, what, there is obvious changes seen on MRI. Patient is in bad shape. We can do much about it. Can you consider fusion? So that is the only, I think, thing I can see. Otherwise, it's very, very difficult to differentiate between discogenic and end plate changes in absence of these radiological findings.
okay. So the last question for this is the how to reach in posterior part of vertebra and cross midline. Do you enter from more lateral to pedicle and also do you perform on bilateral side? Dr.
Yeah, I mean,
Jayaprakash Thakur.
yeah. So basically, just like vertebroplasty, like I like to do extrapedicular approach. Basically, you of course start with the with what you call the upper, like outer part, lateral part of the pedicle, and then in AP, and then when you enter, then when you are in the middle of the pedicle, you have to make sure that you're middle of pedicle in lateral view also, and then try not to cross the medial border of the pedicle when you are entering the vertebral body. So these are, of course, some of the same technique that we use for vertebroplasty. So that's not different at all. So again, gaining extras to the bone, and then of course the rest of it is just you put that wire more inside. You have to make sure that on AP view, basically it's pretty much in the in the middle part of it, and you just cross the midline. In lateral view, it's just like 30 to 50% in front of the posterior border. So these are all just the simple technical things, but the important thing to understand is to first make your clinical diagnosis, because patient selection is very important. And believe it or not, there are times when these patients, in my practice, I see this all the time, that patient has facet arthritis also, patient has modic changes also, and patient has annular tear and high intensity zone on MRI also. So they have all these three things. And you do their spinal flexion, severe pain. You do spinal extension or ipsilateral facet load, patient is in pain. So, it's like sometimes it's combination. And then you have to ask the patient what is more painful. And then when they say, of course, this part is more painful or that part, and then you of course target it that accordingly. But at least for now, we have some option for these patients, especially the anterior column pain patients.
Last question of the evening. What exercise regime will you prefer in cases of modic and plate changes?
Yeah, again, we start with our core stabilization, dynamic core stabilization, multifidi. Of course, your abdomen, like rectus abdominis, oblique muscle strengthening, quadratus lumborum activation, of course, gluteal strengthening, hip flexors stretching, of course, and then of course, your quad strengthening also. So when it comes to our core, basically our core deep muscles as well as superficial muscles, so strengthening and muscle activation, and yeah, that kind of stuff basically, and activity modification also. Yes. Yeah.
So Dr. Chandrapreet Kaur Madam is asking, any blocks will you would like to do before proceeding to BVNA to rule out other causes of back pain to know whether BVNA will be effective or not?
So no diagnostic block required for this procedure. No diagnostic block for
And
now. Yeah.
Dr. Jayaprakash Thakur, do you put any antibiotics inside your body before leaving outside? Do you prefer? Do you put any antibiotic like we do in Viscogenic pain? So do you put any antibiotic before withdrawing your needle?
So we
Anything?
do give IV antibiotics before the procedure, but not
Yes.
inside the disc or inside the bone. But yeah, we
Oh,
do give IV antibiotics before the procedure.
okay. And one last question from my side only. This if how do we stimulate the nerve during this procedure, RFA
No,
procedure?
no stimulation. No stimulation. Again, I know just like Vertebrogenic, when we
Okay,
do
okay.
lumbar passage joint RFA, we stimulate, but not with this. We just
Not
put it
okay.
in, and because patient is usually sedated, so what's the point in stimulating also? But
Oh,
yeah, here, you are pretty much cooking the patient for 15 minutes. So
yes,
if you're
yes,
in
yes.
that right area, 15 minutes is good enough. In fact, the recent, which I don't agree with, but the recent IPSIS guidelines is
Mhm.
even for lumbar facetogenic pain or facet joint RFA, they are not recommending stimulating the nerve or like
Okay.
sensory or motor stimulation before the RFA, which I don't think that's a good. I think we should stimulate, because if we can stimulate, then we should stimulate, and if patient give appropriate lumbar response, then only we should do RFA. But for this BV and RFA, usually stimulation we don't do that or not required basically.
So actually we are short of time. So actually we have a quiz to conduct also. So thank you, Dr. Naman sir, so giving us such a very insightful lecture about vertebrogenic pain. I think Dr. Nitesh Gonade wants to say something. Dr. Nitesh.
First of all, actually, Dr. Naman,
Hello, Nitesh. Hello.
I'm actually on the behalf of Academy of Brain Physiatrists. We are thankful for accepting our presentations, basically your presentation on platform. I have a few basic questions, and again, you have given some points to open the new research, basically, so we can conduct in the future. My first question is, I have seen so many our colleagues, basically, they are giving the oral steroids and even the injectables, methylprednisolone intramuscular. So do you feel is there any role of, as you mentioned in your presentation, there is actually you are also prescribing some oral steroids. So there is a real role of oral steroid in the spinal pain,
So
in chronic pain, basically.
evidence and literature does not support that, but anecdotally I can tell you that I do that in my practice, and that usually it's not like a bad practice, but sometimes it works, not all the time of course. And if you ask for literature evidence, no, literature does not support that, but anecdotally I do that, and it works in some of my patients, so that's why I do that.
You mentioned about the role of PET scan in the spinal pain, basically in the vertebrogenic pain.
SPECT scan, yes. PET scan, I would say, I'm not sure, but maybe. But
So
SPECT scan,
so it can be the area of research, basically, those who want, those really
PET
interested in
scan.
the research work. So
Well,
it can be
again,
the area of research.
principle is again the same, right? I mean, if there is, I think it's all about wherever the increased metabolism or increased fluid or inflammation. So that will light up.
Yeah.
So that's why the SPECT scan is the one. I don't know. I don't know the big difference between SPECT and PET. What exactly the key difference between PET and SPECT? I think PET is more like glucose uptake, if I'm not wrong,
Yes. Yes,
more
yes.
like metabolism rather than inflammation. And SPECT is more like fluid and inflammation. That's why SPECT is better than PET. Even for lumbar facet joint arthropathy, SPECT scan people are saying, because for lumbar facet joint arthropathy there is no evidence, like there's no like reliable MRI or like radiological study. So SPECT scan is studied for facetogenic pain also. So I would say SPECT scan rather than PET scan.
So one last question, basically, can we consider for rami communicants ablation in the
Never done that.
vertebrogenic pain? Yeah.
Well, again, RAMI communicants will only block the sympathetic component, not
Yeah.
necessarily the nociceptive. But yes, if you can, I have never done that. So, but it's definitely you should definitely try it if you can. Yes.
It is ideally useful for the vertebrogenic fracture. So maybe it can work
Yes.
for the vertebrogenic
Yes.
pain
It
also.
can. It can. It makes sense, because I
Yeah.
have read some studies about that procedure that you just mentioned. So I would say theoretically it can, but I have never done that before.
Thank you.
So over to Dr. Minhas and Dr. Rambi for conducting the quiz. And thank you very much, Naman sir, for giving your valuable time to teach us. We are all your juniors and you are very respected senior. So thank you very much, sir.
The type of questions that I received, I'm so proud of the new generation, and you guys are doing amazing work, and please keep up the good work. And I'll be more than happy to do my part. And please feel free to reach out to me anytime. Thank you.
Yes, sir.
Sure,
Thank you, sir.
sir.
Thank you, sir. Thank you, sir.
Sure,
Thank
sure.
you.
Thank you.
Over to Dr. Minhas and Dr. Rambi, please.